Welcome everybody to the first long COVID science interview. Today it's my pleasure to welcome Dr. David Strain, who's a senior clinical lecturer at the University of Exeter Medical School. David, thank you for coming on today. Could you tell us a little bit more about your background and how you got into long COVID research?
Thanks, Jeremy. It's a pleasure to be with you. So, as you say, I'm a clinical lecturer at the University of Exeter Medical School. And in a pre-COVID world, I was the clinical lead of the Microvascular Centre, the Diabetes and Vascular Research Centre, that does a big chunk of the microcircuitry research, around the world. Most of the protocols that are used were developed in our lab. And in part of that, I was already looking at chronic fatigue syndrome to determine whether that had an underlying microvascular cause that just wasn't being detected by conventional measures. Then, as COVID struck, I became a COVID consultant. It was basically a brand new specialty, working every day for about 18 months on a COVID ward, about 15 months on a COVID ward as a consultant clinical lead for COVID within our region. And around October, we started seeing patients coming to our chronic fatigue service who actually had CFS that had come about after COVID. Now, this was already being described, and although there were no real academic manuscripts in it at the time, it was been going on since May in 2020 in the UK, where people had already adopted this hashtag long COVID for the long haulers, people who've got this chronic fatigue syndrome after a relatively minor infection. We then started having conversations about that with the British Medical Association, because at the time I was also chair of the academic staff committee within the British Medical Association and part of their board of science. And then I rapidly became the BMA's representative to the NHS Long COVID Task Force. And so I had a clinical interest in it. It had a massive research overlap with work that I was doing in a pre-COVID world. And all of a sudden I had a political involvement in it as well, representing the NHS task force as they were developing a new service. And that sort of brought everything together, that with the clinical, academic and political, it gave me the heads up and got me involved in the process where we are now.
So how has your experience working with long COVID and CFS patients sort of driven your perspective on the research that you're actually doing?
I find it really interesting. There are huge overlaps between long COVID and the chronic fatigue syndrome and the myalgic encephalomyelitis. And there is this massive overlap. And I'm not suggesting that it is all the same disease. Even within long COVID, there are multiple different pictures, multiple different patterns. We see some people who present with the fatigue, the aches and pains, the brain fog, the insomnia, but the difficulty staying awake during the day and sleeping during the night. And that is very similar to the chronic fatigue syndrome pattern. But we are seeing patients who've got chest pain. We're seeing patients who are more short of breath. We're seeing patients who've got a whole host of different symptoms. And actually, this is really interesting across the board, because what we're seeing are several different conditions that have all been triggered by the same virus. And that does start to raise interesting parallels with chronic fatigue syndrome, where we have similar presentations that have an unidentified cause. And I think what we're now seeing is that this is probably going to be one larger condition with some sort of susceptibility, whether that be genes, whether it be your vasculature, whether it be your mitochondria, or things that we'll talk about in a moment. But all of it is presenting with this similar effect that as yet medical technology cannot pinpoint what the problem is.
Right. And that gets into a dramatic need for research, of being able to understand what is going on, but also importantly, especially from a patient perspective, what we can actually do about that.
Yeah, that is a hugely important point that we're looking at. We need to understand why long COVID even exists. And in a pre-COVID world, as I say, I was trying to do research into chronic fatigue syndrome, and we were struggling an ever uphill battle to try and get the funding to do the research. And you know yourself, Jeremy, we spent half of our life as an academic trying to get funding, about another third of our life writing the reports once we've got funding, and only that much doing the research that we actually want to do. And long COVID has changed that dynamic. What we're now seeing is a big political impetus to help tackle this problem. Because unlike with CFS, where it is a relatively small proportion of the population, and unfortunately, because it happened picking people off piecemeal, it didn't go the same political impact. It never had that political drive to fix. In the UK, we've seen COVID sweep through our population. We have seen millions of people diagnosed with this. As a result, we've been left with about 1.1 to 1.2 million people at this moment in time with long COVID. We've got around 700,000 people with the condition more than 12 months. We've got 122 healthcare workers who cannot work properly because of long COVID. And we've got 70,000 people who have had this for more than 12 months. Now, this has put a massive political impetus on fixing it, not just because of the debilitation, not just because of the injuries that's being caused, but also from a health economic and from the global economic spectrum, that with 1 million people affected by a brand new disease, that translates to, well, it's about 2% of the population who were previously fit, well, and active, who can no longer work properly. And that has driven the need for research. And there's been two major streams. One is understanding the cause, and the next stream, which is due to come online very, very soon, is talking about what we do to treat it.
So when we think about what we can do to treat it, you've recently been involved in a survey study that was looking at vaccines and the impact of vaccination for COVID-19 on long COVID symptomology. So can you tell us a little bit about that study and what you saw?
Yeah, thanks, Jeremy. And you're saying I've been involved, and I just want to highlight for the viewers, Jeremy has also been integrally involved in this, and we've been working together on this. So although he's given me credit, he has done just as much, if not more, work on this as I have. So just a quick overview. There was concern amongst both the long COVID group and also the chronic fatigue population that a vaccine that is going to trigger an immune response might actually exacerbate their symptoms. Remembering that many of us believe that long COVID is a condition caused by an exaggerated immune response. It's caused by your body continuing to have an immune response, whether that be to remnant virus, whether it be to remnant particles, whether it be to targets of the particles. So things like the ACE2 receptor or the Ang1-7 that are all affected by COVID. We don't know what the target is, but there was a huge perception that what we were seeing was an exaggerated immune response. If you give a vaccine that's designed to make that immune response even more active, are you going to make things worse? And that was a real fear, particularly as we started to vaccinate the younger population, the 35 through 50s, who were predominantly affected by long COVID. And so we wanted to go out and ask the people who've experienced this already what had happened. So we put a questionnaire out. It was a very simple questionnaire. It had to be simple because we wanted to get it as widely accepted as possible. And of course, one of the key features of long COVID is brain fog, the difficulty concentrating. So we needed to make sure that the questionnaire took no more than 20 minutes and ideally a 10-minute questionnaire. So we put, from the outset, we do say that there are caveats to this. This is not a complete data set. In total, we got around 900 respondents, and of those, we had a full data set for people with long COVID of 812. We had others who obviously had suffered as a result of their long COVID and couldn't complete it. We also had a population of people with chronic fatigue syndrome who'd gone through the same process and gave us their insights as well. And we will talk about that another day. Now, of those 800 people, we asked them some very basic questions. Do you feel you got better? Do you feel you stayed the same? Do you feel you got worse? And actually, I have to say that was a very non-discriminatory test. Because in the reality, if you've got long COVID and your fatigue gets better, but your brain fog gets worse, which box do you tick? What actually gave us a lot more information was asking if you score your symptoms from 1 to 10 pre your vaccine, then you score those same symptoms from 1 to 10 after the vaccine. How does that compare? And that gave us a real insight. On average, patient symptoms, or the people suffering long COVID, their symptoms got better by around 20 to 25% for the majority of those symptoms. And that was really important. If you look just at the numericals, only 3% of the population felt that all of their symptoms got worse. 7% of the population felt that some of their symptoms got worse and others stayed the same. The vast majority, 57% of the total population, actually their symptoms had improved as a result of the vaccination. Now, I do want to say there's going to be lots of caveats in that. For a start, it's a reporter bias. It's people who experience a change are far more likely to complete it. Whether it be a change for the better or a change for the worse, they are far more likely to complete a questionnaire. The other, of course, is memory. And, we're asking people to remember what were their symptoms like 3 months ago compared to what they're like now. Now, the numbers themselves don't have much meaning. A pain of 5 out of 10 to me might be a pain of 2 out of 10 to another, or 7 out of 10 to a third. However, if my pain was 5 and is now 4, I've got better. If the person whose pain was 7 is now 6, they've got better. And that's a really good way of saying that, okay, so I can't compare mine with you, but I can compare mine before with mine after. And that's why we can be relatively confident that the symptoms got better by about 20%, because that consistency. We also looked at differences between the vaccines, remembering there are different vaccine technologies around. And the two main groups we looked at were the adenoviral vectors. So that would be the AstraZeneca vaccine or the Janssen vaccine, which work by giving you one virus that contains an instruction manual for some components of another virus. And then we compared that with the mRNA vaccines, the messenger RNA. So that's basically Pfizer or Moderna. And interestingly, we did see a difference between these two vaccines. On the most part, people who got the mRNA vaccines, both Pfizer and Moderna, seem better still compared to those with AstraZeneca. Now, that itself as a finding is hugely important. It's not to say that Moderna is better than AstraZeneca. It's different things for different people. But what it says is we are probably not just looking at the natural history of a disease. Remember, none of us really know what the natural history of long COVID is. It could be that these people took their vaccine at the time that they were naturally going to get better anyway. But because there were no difference between the population who got AstraZeneca and Pfizer when it comes to time frame, when it comes to baseline symptoms, when it came to age and sex and geographic location around the world, whether they be in the States or the UK, because there were very little difference in the baseline characteristics, then any differences in the vaccines are probably a treatment effect. Now, I am going to keep stressing this is probably, it's a study of an observation of a questionnaire. What we need to do going forwards is start testing in randomized controlled trials to see, does this actually give us the benefit we hope for? However, what we can confidently say from this, that from the population who answered our survey, the majority, 57%, felt better, and only a small minority had predominant worsening of their symptoms, somewhere between 10 and 15%.
So, I mean, this is really encouraging news, because right now we really don't have any sort of treatments for long COVID. And of course, this is not a full treatment. This is not a cure of long COVID. This is something that potentially has that, improvement of symptomology. But, this is, of course, good news also in terms of being able to help provide vaccine-induced protection for long COVID patients without necessarily worrying that this is going to make things dramatically worse. But I think, two questions that I'm sure people would like to know is, first of all, how long do these effects last? Is this sort of a permanent improvement, or is this a temporary change?
Yeah, I mean, you raise a really important point there, that it's not just that this group got better, it's there is hope on the horizon for everybody who's got long COVID. Because if one thing makes one person better, remember, there is no one size fits all medicine for anything. If one thing makes one person better, then chances are there is something out there that is going to make everyone better. Might be a different something, but it would be there. So going back to how long the benefit lasted, on average, we can say it lasted about 28 to 35 days. But again, there is a big caveat in that one, that we had some people who just said the symptoms got better, didn't come back. That was it, I was fixed. There are some people who said the symptoms got better transiently for 2 or 3 weeks. There are a few people who said the symptoms only got better for 3 or 4 days. And this is where the difference in the individuals come. And again, this is why we need the ongoing studies. Now, one thing we did have within that was a small population, 130 or so people, who'd had their second vaccination as well. Now, the reason this is pertinent, now, many of you watching this in the States or in Europe will be saying, well, of course you do, it's 28 days apart. Remember, in the UK, we had the plan that we wanted to vaccinate as many people as possible with a first dose of vaccine to give the whole population 50 or 60% coverage, rather than targeting getting 90% benefit for a much smaller subgroup. So there was a big proportion of people in this group who'd had their vaccines 3 months apart. That was a really interesting group, because what we saw there is the symptoms got better and then seemed to decline again. But after their second vaccine, they got better. And on average, they got 25% more better second time. And I know that grammar is appalling, please forgive me. So, you get a 20% improvement. And then the second time round, you get a 25% improvement from your baseline. That suggests that this might be an ongoing treatment effect. That suggests in the future, we might be saying, well, a monthly vaccine, you get your monthly Moderna vaccine or your monthly Pfizer vaccine or whatever, and that is going to keep your long COVID symptoms at bay. And we just stretch out how long we need to give it until you just don't need them anymore. And having a monthly vaccine, I mean, it sounds terrible, a monthly jab, but think about it. There are people living with diabetes who inject themselves on a daily basis. There are many other conditions where a daily or a weekly or a monthly injection has become the norm. If you are suffering the symptoms of long COVID, if you are waking up every morning in pain, with a fatigue just walking to the kitchen, the idea of a monthly injection that's going to get you from that to a stage where you can engage with life again, engage with society. And the other advantage that we just have to come back to, the point of this vaccine is to keep us safe. With new variants appearing, the alpha, beta, gamma, delta, as we're now calling them, with these new variants appearing, we do not know whether a previous infection, the one that triggered our long COVID, is going to protect us from a further infection. And if we've got a genetic susceptibility towards it, are we more likely to get a worse exacerbation next time?
Right. So, you've mentioned this idea of, patients responding very differently, that there seems to be, a wide difference in patient symptomology, but also how patients respond. Some having that sort of what looks like potentially a permanent effect of the vaccines and symptom improvement, some having a very temporary, and some patients also worsening. And so, what does this look like? What's the implications of, these results on that small subset of patients that do in fact get worse with the vaccines?
Yeah, that's a really important question because we don't know enough about it as yet. What we can say is because the responses were different by vaccine, it might be a good justification that if you felt worse after your first jab, if you had your Moderna first, maybe you should try the AstraZeneca for your second jab. If you felt your fatigue got worse after the AstraZeneca, maybe go for a Moderna next time. And it might be something along those lines. The other thing is that we still need to boil down is what actually drove those worsening of symptoms. Remember, this is just a questionnaire. It's entirely possible that people had the same level of fatigue. The fatigue was scoring a 7 all the way through. What we will need to tease out in future studies is, can we figure out which people are going to benefit? We're doing different studies at the moment looking at the genetics of long COVID. Genetic testing these days costs 10 to 15 pounds. If you do a genetic test and say, if you've got this genes and then you have this vaccine, you will get better. That really can identify personalized medicine down to a genetic level. And these are all the considerations that we're going to have going forward. We are in a brand new era of medicine, where we are exploring the genetics, the underlying causes, mechanisms that we'd never even thought were possible to look at before. And we're looking at novel therapies. The mRNA vaccines can be tweaked within 6 weeks. If it turns out that one particular strand of the mRNA is actually triggering the benefit, we could end up producing vaccines that are purely along those lines. And remember, there are also the ethical considerations. When there is 3/4 of the world that hasn't seen a vaccine yet, how ethical is it for us to be giving monthly vaccines to people with long COVID when people are still dying of the disease elsewhere? But as we know, the vaccines themselves are moving on. We're looking at second generation vaccines against the new variants. That means there are going to be millions of stockpile vaccines that effectively are useless. Maybe that's a good ethical way to look at those going forward.
It's very interesting. I mean, looking at this globally, I think is, of course, so important, not only in terms of what's going on in terms of COVID infections globally, but, looking at long COVID in many countries where long COVID is not even recognized. But coming back to sort of this patient level is, this is really interesting, that idea of looking at patient genetics, looking at trying to understand more about the disease itself and why patients have different symptoms, why those symptoms change over time in different ways, and why certain patients respond to different treatments like the vaccine in different ways. Because of course, we need to make sure that we have treatments that work for the majority of patients, but that we're not leaving any patients behind, that just an average effect is not enough. We need to make sure that we can have something, as you said, that is going to improve symptoms for everybody. So could you tell me a little bit more about that sort of genetic study that you're involved in, what that's looking at, where you are on that data?
So we are very, very early in that study. We're collecting genetic samples from around 5,000 people with long COVID from around the world. And the intention then is to do a full genetic screening versus many of the other databases of people who haven't got long COVID. We're using a very common platform. In the UK, it's termed 23andMe, but there are many genetic ancestry that all use this same platform. And from this, we can find out what the average genes of the world are, basically, from your geography, from where you live, and the local surrounds. And what we can start looking for is genetic association with the certain characteristics. We're using a very similar questionnaire in that study that we used in our long COVID study. So the same 11 points of symptoms and figuring out which are the particular fatigues. And what we hope to be able to do is identify a phenotype, that is the physical presentation, what you as a person suffering with this condition experiences, and associate that with the genes. And then we can start saying, if your genes are like this, then you are more likely to have those symptoms. If you've got those symptoms, your genes are more likely to have that. And therefore, for you, this is the treatment, whether that be a vaccine, whether it be one of the many other therapies that people are trying and reporting success with, whether it be vitamins, or whether it be the antihistamine therapies, or simple things like aspirin, which some people are reporting benefit with. And maybe if we can pick up a genes or the presentations and say, okay, if you've got this and you've got this, you've got a much higher chance of responding to this. In our study, as you say, 57% of people on average responded. On average, symptoms got better by 20%. And within that, there's a cohort that actually got all the way better. There's a cohort who went from having fatigue levels of 7 or 8 down to 0. They got better completely. The gold standard would be to see somebody in our assessment service, to put a collection of symptoms together, to do a quick buccal swab, the same as we do to confirm that we've got COVID, to do a genetic test, which comes back in a couple of days. Costs these days £35, $50 to get a full genetic profile. And being able to say, okay, on the basis of this, we have about a 90% certainty that this treatment will work. Or we've got a 10 to 15% chance that this is going to make you worse, and only a small chance it's going to make you better. So let's avoid this one and try this one instead. And really, this is, I say, it's a new age of medicine. And what we have is a brand new condition at the same time that we've got these new technologies. This holds hope for the people who are currently suffering with long COVID. And actually, coming back to the original starting point, it also offers hope to those with other similar conditions, the chronic fatigue, the myalgic encephalomyelitis, who've been suffering with these conditions for 30 or 40 years. And there's many of them who can feel rightly that we've been ignored for decades. Why are all these people getting the attention? And part of that is a failure of the politicians to acknowledge this as a significant disease. But part of it, it's an aligning of stars. This condition has come about at the same time. The technology to do genetic testing, the technology to do microvascular assessments and mitochondrial function assessments have all come about. And at the same time, the technology to engineer an mRNA vaccine in 45 days, all of this has occurred at the same time. And hopefully the knock-on benefits from many other conditions will be huge.
Yes, I mean, we are at a very interesting point in time. I mean, and as you're talking about, everything from, looking at diagnostics that can be, really examining microvascular changes that you might not be able to see in standard assays, to looking at things like mRNA vaccines and ways to tweak the vaccines very quickly, very affordably, to really optimize the effect. So if you sort of step back and are looking and say, okay, this is where we are technologically, this is where we are research-wise, what do you see as the next big studies, the next big steps that are either in progress for long COVID or need to be done to really understand what is going on and what we can do about it?
So at the moment, there are the need for these two different arms. There is the need to understand why, understand who gets it, why they get it. Was there anything that we could have done to prevent it? Was there anything that could be the people who didn't get it that are genetically similar with a similar strain? Why did some get it and others not get it? What can we do to protect people from getting it in the future? And then for the 10% of people who got COVID and have been left with these symptoms, we need to be testing the different treatments that are available. Now, that's going to start off with pretty crude testing. And one of the things that there's a group of us that are already planning, we're hoping to get some money from NIHR in the near future. And we're speaking to the manufacturers of these, the vaccines, to start looking at doing, we call it an adaptive designed prospective randomized controlled trial. In the first instance, we're just going to get 4 groups. We're going to say, okay, you are 4 groups of people with long COVID. We're going to get lots and lots of details about you. And these are the things that people have suggested will be benefit. So in a randomized controlled trial, we're going to try giving the 4 groups the therapies that we know are safe and might be of benefit. And then as things progress, we can say that, well, okay, loratadine or famotidine, that is clearly working if you've got this, 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 and this. So I'm going to stop that study. I'm going to make that the recommended treatment for those people. And we're going to replace that arm of the study with vaccines or N-acetylcysteine or vitamin D, and I'm just listing off a whole load of things. Please do not rush out and buy vitamin D capsules or any of these other things. These are just things that are random suggestion that some people say have worked for them. And we do this in adaptive design. And as we get to know more, as we get more data, as we get bigger databases, then we'll be able to link the genetics with the outcomes, with the phenotypes, the presentations. And as a result, we'll be able to have truly personalized medicine. The other thing that's come about at the moment is the use of big data. The National Health Service has currently got 55 million patients' records in one place, all being treated in different ways, but with the same coding structure. That means going forwards, the idea of looking at long COVID in these populations, we might be able to pick out patterns. Was it because before COVID, they were all taking, I don't know, metformin for their diabetes? Was it because they were all in the northern parts when the sun was flowing in a certain direction? Is it because they all had good vitamin D, or they were all teetotal, or because they all had alcohol? Whatever. And these are the sorts of questions that we can ask on these big data sets of the multi-million patient sets. In the future, it's hoped that we'll then start to cooperate internationally, bringing together UK data sets with states, with data sets in the States and in Canada and across Europe that are all using the similar SNOMED codes. Can we start putting things together, and can we start looking at literally hundreds of millions of patients to say, okay, this is what we could have done better, and this is what we're going to do to protect people going forward.
So, I mean, this is all very interesting and really encouraging developments, both technologically as well as the implications for long COVID internationally. And I know, we both have a lot of experience in doing research in how long it takes to put together these studies, to get funding for these studies, to complete these studies, and for that to then translate into patient benefit. But I know for a lot of patients sort of watching this and saying, well, there's been this huge investment. There are all these studies going on. There's all this research. There's all this talk. And yet we're still waiting on something that's actually going to have an impact. So when you sort of look and say, is there anything that could be done that would actually help this process go faster? What is needed to get to that point where we can actually offer patients something soon?
Yeah, so that's the $1 million question. Let's just take a similar disease in perspective. Multiple sclerosis. If you'd have known somebody with multiple sclerosis 30 years ago, they were very often told that this is all in your head. It's a psychosomatic illness. There's this waxing and waning disease. And the reason for that was because the blood tests at the time, the imaging at the time, all came back normal. It's taken us 30 years from going from a condition with normal blood tests and normal imaging to having advanced localized immunoglobulin-based treatment that can be identified those, selected them using the right MRI technology and the right screenings and the right coils, and then you have specific monoclonal antibodies against the myelin basic protein that's leading to all this. And what you end up with is 30 years worth of history to get from a disease that we don't know what causes it to focused treatments. That's the sort of timescale that treatments normally take. We can't wait 30 years for people with long COVID. And one of the things that is taking place is massive investment. Both you and I know that a big part of research is applying for grants. It's waiting for it to come around. It's waiting for those results. Normally, it takes 18 months to go from an idea to a grant being accepted, and then another 6 months before you're ready to do research. What's happening with long COVID is in the UK, there was an announcement in October that we're going to have a grant round that's going to look towards looking at the underlying causes of it. That was announced on the 5th of October. On the 19th of November, cases closed. On the 12th of December, £20 million was thrown at research into the underlying causes. Around April time, it said, we're going to have another round of grants that will say, what are the treatments for long COVID? £20 million announced at the start of April, closing date on the 5th of May. We're due to find out sometime next week which strands are starting, and the anticipation, if we're one of the lucky ones who gets some of this money, we are planning our first study to start on the 6th of July. This is a time frame that in itself is unprecedented. Of course, the next hurdle as researchers we face is getting the ethics approval, getting all of the bits, and that's mostly filling out paperwork and waiting for the right people to look at it. With the ethics approval for a COVID study, we go from starting the paperwork, which is a simplified, just asking the pertinent question once rather than triplicate. And then we are guaranteed a 2-week review of that. Now, 2 weeks sounds a lot to someone who's not used to dealing in ethics, but actually 2 weeks compared to the 3 months it normally takes is tremendous. And then the last thing we've got going in our favor is we have a tremendously motivated group of people who want to be part of our studies. In a pre-COVID world, I did a study with 2,400 people. It took me 3 months to get those 2,400 people recruited for a study that was effectively, we want to take urine samples, we want to do genetic testing on you, and then we want to follow you up via phone calls over a 6-month period. It's 3 months to recruit 2,400 people. Sorry, 3 years to recruit 2,400 people. In the COVID vaccine trials, it took them 3 weeks to recruit 20,000 participants. If we go global on these sorts of studies, we will expect to see 5,000 or 6,000 people recruited in the first month. And of course, the more people who get recruited, the quicker we can get these studies going and the quicker we can find out. We need 400 or 500 people to say whether a drug's working or not. If it's not working, we drop that arm and we move on very quickly. We don't do the let's collect 3 years worth of data and stop and review. We include in our statistical analysis that we are going to have interim analysis at 100 patients, 300 patients, 500 patients. And if at 500 patients there's no evidence that it's benefiting, it gets dropped and we move on to the next treatment. These are differences in the way that we actually do the research. We're still going to be looking at 12, maybe 18 months before we have an answer. But that's 12 to 18 months for an answer versus 30 years for similar conditions historically. I know that feels incredibly slow if you are that patient who wakes up every morning with muscle aches and pains or fatigue or the brain fog. But just know that things are changing to get the answers to you as quickly as possible. And you never know, we may look out. It may well be that the first thing we trial works for 80% of the population, and all of a sudden we have the treatments in front of us.
Thank you. Yeah, I know that seems like a long span of time to wait, and of course, every month within there is a long time to wait. But it's not just that one time point and then we have an answer, but there's that potential, that ongoing potential of new discoveries, new potential treatments during that whole period of time. So just to sort of wrap things up with the sort of last question for you here is just, in the sort of more near term, say the next couple months, what do you see as a sort of outlook for the next couple months? Is there anything sort of coming down the pipe soon in terms of either our understanding of long COVID, treatments of long COVID, or really the sort of disease progression. Is there anything near term that you're sort of looking at and sort of awaiting?
So the short-term things that we know we can get quickly are based on things that we already have data for. We are, of course, following up the 1.2 million people with long COVID in the UK at the moment. We're looking very carefully at their records compared to the records of matched population. If we match them 3 to 1 with people who got COVID versus those who've got long COVID, and we match them again with 3 to 1 with those who didn't get COVID but were in a similar environment, then we can start understanding what may have predicted it. That's going to be integral to making sure it doesn't happen again. The next thing is to look at the people who seem to be getting better. Find out what they're doing that's different. Could it be that the people who are getting better are all on aspirin for other reasons, or they're all on multivitamins, or they're all on other things? And those sorts of answers are things that are on the shelf now, ready to go. Repurposing what we already have. And that's going to be major data crunching. That's going to be major numbers. And we're looking at, millions of data set in order to do that. However, they're the sorts of answers we're going to have in the near future. And when it comes to repurposing, if you've got, if we can demonstrate that of those with long COVID, the ones on multivitamins seem to get better very quickly, I would hand on heart happily recommend multivitamins, because I know it's not going to be harmful. And if it's beneficial, even in only a third, they're the sorts of things that we can start saying. The trial's going to be 12 months before we've got the data, but the things that we have in front of us today are those sorts of data. The intermediate term, I think that is going to be the vaccines. And as I say, this difference between Moderna and AstraZeneca that we saw within our study, that could mean people with long COVID are recommended, you need a vaccine anyway, get the Moderna vaccine, and we can get them funded centrally. If you did get your benefit and then you got more benefit after your second, we can justify trialing a third, a fourth, and a fifth, because that is a relatively simple intervention that will give you symptomatic relief. Going forward, longer term, lots way down there, lots to be hopeful for, but they are our short-term goals.
Excellent. Thank you very much. And thank you for taking the time today to share your experience in the research, your perspective on the research field. Thank you very much. It's been a pleasure to have you on today.
You're welcome, Jeremy, anytime.
Thank you.